Hello, today we're going to be talking about ankle MRI bone marrow edema patterns, and this is part one. First, we're going to be talking about the traumatic causes, and in a second sister module, we'll be talking about non-traumatic causes of bone marrow edema. The aims of this talk are to describe patterns of bone marrow edema on MRI of the ankle associated with trauma. To increase awareness of common associated traumatic soft tissue injuries that can be associated with traumatic bone contusions, and to describe a strategy to help differentiate between traumatic and non-traumatic causes of bone marrow edema in the ankle. There are many causes of bone marrow edema in the ankle. On some of these slides, I will list some additional non-traumatic causes, but the traumatic cause will be highlighted in teal, as you see here. Let's talk a little bit about the pathophysiology of bone marrow edema. There's a little bit of debate about how this comes about, but in general, it is felt to represent an accumulation of fluid, blood products, fibrosis, and necrosis, probably a combination of those factors. On MRI, in general, bone marrow edema is hyperintense on the fluid-sensitive sequences and is hypointense on the T1-weighted sequences, although the degree of T1 hypointensity can vary. A multifocal pattern of bone marrow edema we'll talk about both here under the trauma section and the non-traumatic section. There are many different causes for a multifocal pattern, and there may be more than one cause at once manifesting in an MRI that you're looking at. This is a case of a 20-year-old soccer player. This is a stress reaction caused by repetitive loading forces, and it's on the spectrum of stress injury and stress fracture, but you'll see here there's no discrete fracture line. The arrows are pointing out the bone marrow edema in the distal tibia, involving mainly the medial malleolus, also in the distal fibular tip, and in the talus, particularly anteriorly and in the medial aspect of the dome. Another cause related to trauma for a multifocal pattern would be immobilization, as in this patient who is a 21-year-old male with several weeks of immobilization, and you can see it is a very sort of indistinct patchy pattern of edema, no discrete fracture lines. It's felt to be caused by a disrupted vascular autonomic innervation, and the distribution pattern is often peripheral as well. Within part of this talk, we will focus on individual bones to try to help compartmentalize both the injuries and soft tissue injuries in a certain section of the ankle. So this first slide involving the distal tibia, this is in a 57-year-old male who did not have a history of trauma, but you can see here the arrow is pointing out a fracture line, low signal intensity on both the T1 and T2 weighted sequences with surrounding edema. You may or may not see a fracture line with a stress injury or contusion. In this case, we do, and we'll talk in a moment about the soft tissue injuries in this region that can be associated with this pattern. Often you'll see sort of kissing contusions between the distal tibia and talus. When you see this pattern medially involving the medial malleolus and the more medial aspect of the talar dome, as in this case, you have to think about injury to the deep deltoid ligament fibers. As you can see in this case, there is a thin linear area of fluid in the deltoid ligament fibers that is at least a partial tear in this instance. If the pattern of bone marrow edema is located higher up and obviously more laterally, you have to consider whether you have an injury related to a high ankle sprain or injury to the syndesmotic apparatus, which would involve the anterior or anteromedial aspect, the deltoid ligament, or anterior tibiofibular ligament injury, or posterolateral aspect, the posterior tibiofibular ligament. Some more examples of bone marrow edema in the medial malleolus of the distal tibia. In this case, the injury, the soft tissue injury, involves the flexor retinaculum. You can see this number 1 is pointing to the flexor retinaculum, which is distorted and surrounded by edema and fluid with an adjacent contusion in the medial malleolus. This was a 39-year-old, 10 days after an injury. Here's an axial image showing the similar region, different patient. The tibialis posterior tendon is being pointed to here by arrow number 1, and we can see that within the substance of the tendon, there's disruption of the tendon fibers, there's abnormal high signal intensity and some tenosynovitis, and with adjacent bone marrow edema in the tibia. I have put a companion image, a different patient, normal patient, on the right-hand side here, just to show you what normal should look like, with the normal tendon being very homogeneous and low signal intensity and no adjacent bone marrow edema. Bone marrow edema in the distal fibula, similar causes as we discussed to the distal regarding the distal tibia, but in this case we have a mildly displaced fracture fragment pointed to here in this image by arrow number 4. The fracture fragment is displaced distally a couple of millimeters, and we have bone marrow edema not only in the fragment but in the underlying distal fibula with adjacent ligamentous injury. The avulsion in this case was caused by avulsion of the posterior talofibular ligament, which is being pointed to here by arrow number 3. And again, I have a companion image on the right-hand side of the more normal anatomy in a different patient. There may be times where the bone marrow edema pattern is a little confusing because there are some underlying cystic changes and no soft tissue injury that you can really identify, and you get this history of pain as in this 42-year-old male. And this arrow number 1 is pointing to the subcortical cysts and a little bit of bone marrow edema in that area. And in this case, this was this is chronic repetitive injury, some traction cysts related to chronic traction involving the posterior talofibular ligament. When you see bone marrow edema involving the lateral or posterolateral aspect of the distal fibula, you need to start thinking about injury to the superior perineal retinaculum or friction related to perineal tendon pathology. And in these images, first we have some axial images and we have a sagittal image demonstrating abnormal signal in the perineal tendons, and in this case, the peroneus brevis tendon. You can see that arrow number 2 is pointing to has abnormal increased signal intensity and fluid in the tendon sheath. And that is consistent with tendinosis and tenosynovitis. And I have an image below here, again, just demonstrating a more normal example of the peroneus longus and brevis tendons posterior to the distal fibula, with no associated bone marrow edema. And the upper images here were a 59-year-old female with a history of 10 months of pain. Jumping back to the region of the talus now, when you see bone marrow edema in the talar dome, we often think, oh, we should look for an osteochondral lesion. That may or may not be, what you find, but if you look closely, you'll at least find some, often you'll at least find some overlying chondral injury, cortical injury. Remember, you may have superimposed osteoarthritis. But in this case, the arrow is pointing to a very small little chondral defect, which you can see, and with some overlying thinning of the cortex and adjacent bone marrow edema. And in this case, there's no well-demarcated osteochondral fragment. We don't have an osteochondral lesion here per se, and there's no unstable fragment. And this was a 19-year-old, excuse me, with a 3-month history of ankle pain. Now, this patient has a very well-demarcated osteochondral lesion with bone marrow edema in the talar dome fragment. And the key thing that you're looking for to decide whether you may have an unstable fragment is a little fluid interface between the fragment and the underlying marrow, which you can see in image A here. You can see that you could almost lift that fragment out. And so that could be the cause of this patient's pain, a 29-year-old with 4 months of medial-sided ankle pain. Sometimes the margin of the fragment is much more well demarcated on the T1 weighted sequence. As you can see here, it very nicely depicts the lesion in the sagittal plane. Other injuries related to the talus may involve the avulsion injury of the talonavicular ligament. As you see here, the ligament is thickened, it's heterogeneous, abnormal increased signal intensity and bone marrow edema, either within the distal talus or within the adjacent navicular surrounding soft tissue injury. And often on plain film you may see, or on a CT you may see a displaced cortical avulsion fracture here. You have to be a little bit careful because sometimes there's an ossicle in this region, and you wouldn't want to mistake a fracture fragment for an ossicle. Look for the margins of that fragment to look acute and not well corticated, although a well corticated fragment could also mean an old injury, old ligamentous avulsion injury. So that would require taking some of the clinical history into account. Sometimes you just can't tell, but on MRI, this is an obvious case where there's injury involved. Lateral process fracture. This became much more common an imaging finding with snowboarding injuries a couple of decades ago. And again, so you'll see bone marrow edema in the lateral talar process and usually in the adjacent distal fibula and calcaneus. Injury to the sinus tarsi can result in bone marrow edema in the adjacent calcaneus and talus, and other causes may include deposition diseases or inflammatory arthritis. In this case, we have stress fractures in the, just more examples I'm going to show you, linear stress fractures in the distal tibia and in the calcaneus. In this 57-year-old with 4 weeks of hindfoot pain. You're really not going to see these radiographically, or they're going to be very radiographically occult. You may see it on CT, but MRI is really sensitive for picking these up. Plantar fasciitis, that's another, when you see bone marrow edema in the posterior inferior calcaneus, look for abnormal signal in the plantar fascia and surrounding the plantar fascia associated with plantar fasciitis. And also bone marrow edema in the calcaneus in the region of the perineal tubercle can be an indication of injury involving the peroneus longus tendon. As we have in this case, we have abnormal edema and fluid surrounding the tendon and bone marrow edema in the adjacent calcaneus. And this is in the axial plane. Achilles tendinopathy, the posterior superior calcaneus. We'll often see abnormal signal intensity in the Achilles tendon, maybe retrocalcaneal bursitis. This was a 49-year-old male with chronic pain. And occasionally we'll see bone marrow edema in an ossicle, and in this case this was a fracture of an os peroneus. So be on the lookout for that. So in summary, post-traumatic patterns of bone marrow edema may result from chronic microtrauma or acute traumatic events. And soft tissue injuries can be predicted from patterns of traumatic bone injury and should be included in the radiologist search pattern. Thank you for your attention.